in twins. The alternative is the combined test, which we are all using. But the combined test has a very low detection rate in twins as compared to single twins. It's only 75%, with a false positive rate of around 9%. Now, a high false positive rate is a particular problem in twins, because when you have such a high false positive rate in twins, especially in DC twins, you have to do a lot of amniocentesis. We'll have to do a double amniocentesis in a dichorionic pregnancy. And if one of them is abnormal, we will have to do late selective reduction. So this high false positivity in the combined test is a cause of concern for the combined test with such a low detection rate of around 75%. And that's where NIPT comes in. Now, NIPT works differently for monochorionic twins and dichorionic twins. We know that the principal factor of NIPT is the fetal fraction. And in twins, we know that the placenta is bigger, and therefore the fetal fraction is going to be higher. The fetal fraction in twins is 16% in twins, 35% higher than in single twins. But the individual fetal fraction is much lower, around 7.8% in twins compared to 10% that you would see in single twins. So even though the combined fetal fraction of both the placentas is higher than in singletons, if you look at the individual contributions, they are less. So what does that mean? It means that in monochorionic twins or monochorionic pregnancies, because you're looking at a single embryo that splits up, you're looking at fetuses that have the same genetic makeup, the higher fetal fraction works in our favor, because the higher fetal fraction will allow us to say whether this baby is normal or abnormal, and because they have the same genetic matter, it doesn't matter actually whether the fetal fraction of one of them is less. And therefore, in monochorionic twins, it is much more accurate than singletons. In DC twins, there is a problem. The problem is the fetal fraction of one of these fetuses can be less than the desired value. For example, there are two fetuses, fetus A and fetus B. The combined fetal fraction is 16%. But the fetal fraction of fetus A is less than 4%. And what if that fetus has aneuploidy? It could be totally missed. It leads to high number of false negatives. And if you're looking at the separate fetal fractions and deciding on your no-call rates, you would see that there is a 3.3 times higher failure rate than compared to singletons. So what works in DC twins? What works in DC twins would be an SNP-based NIPT, where you look at this unique signature within the DNA of both these fetuses and find out the fetal fraction of each fetus, fetus A and fetus B. And if the fetal fraction is adequate, then you go in for NIPT testing. But it's difficult because SNP-based tests are not widely available and currently not used much in India as well. But let us look at the evidence of the other forms of testing. Let us look at NIPT that is routinely used in singletons and see how it performs in twins. The FMF did that study in 2019 where they looked at cell-free fetal DNA testing for twins irrespective of their chorionicity, and they found that they had a detection rate of around 98%. Asma Khalil's group also did the same and found that they had a good detection rate of around 100%. So what's the final verdict? It is the best test for trisomy 21 compared to the available forms of screening. And the available form of screening is the combined test, and the combined test is not as good with a detection rate of only 75% and a false positive rate of 9%. So definitely NIPT is better than the combined test. In monochorionic twins, there is no doubt we are not worried about the fetal fraction of each of these fetuses separately, and therefore it is a very, very good test. In DC twins, it is better than the combined test, but there is still a worry about fetal fraction being a problem and leading to false negativity. And therefore, if an option of an SNP-based test is available, that would be the best test in twins. As far as trisomy 18 and 13 are considered, both these studies that I showed you right now showed high detection rates, but they also said very clearly that the numbers are not big enough to be used in regular clinical practice. So for twins, For trisomy 21, you can use NIPT, but you should understand that there is a high false negative rate in DC twins, and that is something that has to be kept in mind. What about copy number variants, micro deletions and duplications? Now, NIPT is good at trisomy 21, 13, 18, sex chromosomes. But we need to know more. We need to know about micro deletions and duplications. We need to pick out those rare syndromes, because that's where all this problem is. And that's why copy number variants were looked into. Now, copy number variants are micro deletions or micro duplications that are less than 5 base pairs. And this micro deletion can lead to a monosomy of a segment, or a micro duplication can lead to a trisomy of a segment. That means overrepresentation or underrepresentation. Now, there are two types of copy number variants that can be detected on NIPT. One is to do for specific abnormalities like 22q, 15q, 5p, 1p36. Now, these are specific chromosomal abnormalities that you're going to try to pick up. The other method of doing NIPT for copy number variants is to look at the entire genome and look for anything that is abnormal. Now, the primary concern here is that in copy number variants, we do not know anything about fetoplacental mosaicism. Like confined placental mosaicism, it is possible in copy number variants as well. Except for 22q deletion, the prevalence of the other copy number variants in the general population is not known. And the biggest hurdle probably is genotype-phenotype correlation, which means you have a genotype, but how confident are you that the phenotype is going to be abnormal? For example, if I have a karyotype report saying that there is trisomy 21, I am confident that the phenotype is going to be a little bit similar to trisomy 21. There is going to be an abnormality that is typical of trisomy 21. But I'm not that sure when it comes to other microdeletions or duplications. And there is a high false positive rate and low positive predictive value for all these microdeletions. Let me explain that a little bit more clearly using the example of 22q deletion, which is by far the commonest one. With the prevalence of 1 in 1,000, it is the second most common cause of congenital heart disease. Now, the biggest hurdle in 22q deletion is what I told you before, genotype-phenotype correlation. How confident are you that when you pick up a fetus with 22q deletion, the child will have an abnormal phenotype? And for that, this paper is phenomenal. This paper looked at fetuses or looked at adults and children who were diagnosed with 22q deletion after a relative was diagnosed. So what this study did was that they looked at all those people who had a result showing that they had 22q deletion only after a relative was diagnosed, which means they were all normal individuals. And they found out that they had 22q deletions. And none of them had a significant or insignificant finding. In fact, 68% of these adults and 45% of these children who were having 22q deletion did not have any phenotypic expression of that abnormality. So you can imagine how difficult it is when you do an amniocentesis and find out that there is 22q deletion in a fetus that is completely normal. How do you predict that that fetus is going to be normal or abnormal? And also there is this concern of high degree of false positivity that is possible with copy number variations. And that was clearly elicited in this study, which looked at 287 consecutive pregnancies in which they looked at microdeletions and duplications. And I'm not going to read this entire result, but I'm going to draw your attention to 22q deletion. In their study, they found 7 cases on NIPT which showed a positive result for 22q deletion, out of which 2 were only having an abnormality in the fetus, whereas the rest of the 5 were found to be normal when an amniocentesis and an array was done. So out of the 7 that were picked up on NIPT, only 2 were true positives, whereas 5 were false positives. And most important of all is that none of them had a structural abnormality. So what do you do with these fetuses that turn out to be positive for 22q deletion with no finding on ultrasound, nothing to suggest that there could be a phenotypic abnormality. The headache does not stop there. If you pick up a microdeletion on NIPT, you have to do a confirmatory test. And the confirmatory test for a microdeletion is a CGH microarray. And when you do a microarray, you're going to get things that you're not prepared for. You will get a result which would have of no significance, like it will have variants that are of unknown significance, and that can happen 3.5% of the time. And when that happens, again, you will have to look at the parents to see from where this variation came from, and it will lead to a complete vicious cycle where you go from the child to the parent to the child again, and you will be stuck in that whole series of tests with no end in sight. And that's why right now we are not ready to use copy number variations or microdeletions and duplications as a part of NIPT in an unselected low risk population. So we've covered a lot of ground now. We have looked at NIPT in singletons, we have understood NIPT in twins, and we have looked at NIPT and copy number variations. Now, how can we clinically implement this? That's the key, right? To implement a good test. Now, one method is to use NIPT for all. Now, if you do NIPT for all, you can get a 97 to 99% detection rate for a 1% invasive rate. But the problem here is that when you do a test like this for all, the cost is going to be too high, and universal testing with NIPT is probably not possible in low resource settings. It is less accurate for trisomy 18 and 13. You will miss out on all those clinically significant aneuploidies that I talked about, and you cannot screen for preeclampsia, FGR, and other anomalies if you just do NIPT and bypass the combined test or the NT scan. So the best thing would be to use best of both worlds. Use the NIPT and the combined test in a contingent form of screening. So your baseline test is going to be the combined test, and with the help of the combined test, you're going to divide your population into low risk, intermediate risk, and high risk. And it is the high risk group that will probably need an invasive testing. The intermediate group can have NIPT, and the low risk group needs no further testing. But where do you set the cutoff? How do you decide which is high risk, which is intermediate, and which is low? And if you remember what I told you right at the beginning, 78% of all clinically significant aneuploidies are present in that group that has a high risk on the combined test where the cutoff is above 1 in 100. And if you drop that risk to 1 in 10, you would still pick up 50% of clinically significant aneuploidies. Now, that 1 in 10 number was what was used by the Fetal Medicine Foundation and the Barcelona Fetal Medicine Group, where they said that you could do a combined test and divide them into 3 groups: 1 in 10, 1 in 10, and 1 in 2,500, and greater than 1 in 2,500. So the group that is in the 1 in 10 group can have invasive testing with microarray. The one that is between 1 in 10 to 1 in 2,500 can have NIPT, and greater than 1 in 2,500 needs no further testing. And when you do that, you will have a detection rate for trisomy 21 that is close to 98%, with a 0.8% invasive test, and 25% of the entire population will get NIPT. It's still too expensive for us because 25% of our population is still high. But they had a significant impact on something else, and the impact was their invasive testing rates. After the implementation of NIPT in Europe, they found that there was a 58% drop in the amniocentesis rate and a 77% drop in the CVS rate. So bringing the cutoff to 1 in 10 created a huge drop in your invasive testing rates, which in turn means what? You're not going to lose out on normal babies in your endeavor to pick up abnormals. But what is the current practice in India? The cutoff is still kept at 1 in 250. And NIPT is offered for the intermediate risk group between 1 in 250 to 1 in 1000, and greater than 1 in 1000 is classified as low risk. So what's happening here? If you keep your cutoff at still 1 in 250, there is no reduction in your invasive testing rates. The amount of amniocentesis that you're doing before, the same amount you will be doing now, because your cutoff for the combined test is still 1 in 250. In fact, your invasive testing rate is going to increase because you're going to do NIPT, and we know that NIPT is going to show a lot of false positives and also going to throw up a no call rates or no result rates. So for all those no calls or false positives that come up on NIPT, also you're going to give invasive testing, and so your invasive testing rate is not going to go down if you keep your cutoff at 1 in 250. And that's why we have proposed this, and we have been using it at our center too, is to use NIPT to our advantage, not just ours, but to the patient's advantage as well, and to bring your cutoff from 1 in 250 to 1 in 100. So when you bring your cutoff to 1 in 100, you're going to reduce your invasive testing rate. At the same time, in that 1 in 100 group, you're going to pick up 78% of all clinically significant aneuploidies. For 1 in 100 to 1 in 1000, you can offer NIPT, and greater than 1 in 1000, you don't need to offer any form of testing. So by decreasing your cutoff, you are decreasing your invasive test rate, and also by increasing the intermediate risk group to 1 in 1000, you are picking up all those Down syndrome babies that you would have otherwise missed. So here, by using this different cutoff, you are increasing your detection rate for Down syndrome, you're reducing your invasive test rate, you're picking up all those clinically significant aneuploidies. And that's why we feel that the best cutoff would be 1 in 100 for the general population, at least in a low risk or a low resource setting. Now, having done that, having understood all this about NIPT and cutoffs, let's read a few reports, because reading reports is also important to understand what a report is telling you. So let's read this first report. Case 1, 34-year-old multigravida, combined test shows combined in intermediate risk, and the NT scan was found to be normal. So she is basically an intermediate risk group on the combined test, and therefore we offer her an NIPT. Now the NIPT showed this. Clearly you can see that the chromosome 21 shows high risk. So when you see an NIPT result that comes out as high risk, and you want to guess whether this is actually true positive or false positive, what is the first thing that you look at? You look at the fetal fraction. The fetal fraction is extremely good. Anything above 4 is good. This is 16.4%. So there is a very high fetal fraction. Next thing what you need to look at is the Z-score. And what is the Z-score? The Z-score is only 4.47. It is less than 6. So here you have a condition where you have a high fetal fraction and a low Z-score. So what is the positive predictive value? Is it high or is it low? It is low, because when you have a high fetal fraction, if it is a true positive, you should have a high Z-score as well. And that is exactly what we saw in the result. The result turned out to be normal. Here is another case, unbooked primary gravida, no screening at all, ultrasound was normal. They did a direct NIPT. And on NIPT, this is what we saw. Chromosome 18, high risk. So what is the first thing that we need to look at? Again, we look at the fetal fraction. 4.46, not very good, just above 4. And look at the Z-score, not very confident, less than 6 with a low fetal fraction. So you're looking at low fetal fraction, low Z-scores, normal ultrasound. So you're looking at a false positive rate that is going to be high and a low positive predictive value. And therefore, in this case, you shouldn't do a CVS. You can go in and do an amniocentesis, and the amniocentesis showed that there was a normal fetus. Here is another lady, 43 years old, directly went for an NIPT because of her age-related risk. NT scan was normal, combined test was not done. She directly went in for NIPT. And this is what the NIPT result showed. There was a high risk for XXY and XYY, around a very high risk on the Z-scores. So what is the first thing you do? You look at the fetal fraction and the Z-scores. Now both are high. The fetal fraction is high and the Z-scores are also high. But what is the abnormality that has been predicted? It is sex chromosome abnormalities. So high fetal fraction, high Z-scores, normal ultrasound mean nothing here, because a high Z-score is possible in maternal mosaicism, and in spite of the high fetal fraction, you can get a false positive result. And therefore, in sex chromosome abnormalities, you should remember that there is always going to be a low positive predictive value. And when we did the karyotype, that's exactly what we found. There was normal sex chromosomes with a variation of 9QH plus, which was not of any clinical significance. Now that's how you read a report. Do not just go directly and see high risk and low risk. Look at the fetal fraction, look at the Z score, look at the type of abnormality, look at the ultrasound, and then counsel the patient. Do not scare the patient directly by saying that the NIPT is abnormal, this baby is definitely going to have Down syndrome and things like that. There is a high chance that the test could still be normal, and you can interpret that by reading the NIPT result properly. Now, before I end, I would like to talk about a few common clinical dilemmas that are there with NIPT. There are three scenarios that I would like to address. The first one is an abnormal USG finding. The second one is picking up a soft marker after a low risk result on NIPT, and the third one being a previous affected child that has not been worked out. For the first scenario, when you have an abnormality on ultrasound, this could be a structural abnormality or it could be an NT value that is greater than 3.5. Whenever you have such kind of abnormalities, do not do an NIPT. The best method is to go in for amniocentesis and preferably a microarray, because 8% of the time you will get additional aneuploidies that cannot be picked up on NIPT. So there is no point in doing the NIPT and wasting time and giving false reassurance in this group where the NT is high or there are structural abnormalities. The second condition is you have done an NIPT. NIPT has turned out to be normal. And then at your 20-week scan, you pick up a soft marker like an absent NP or an aberrant right subclavian artery. Now here you have to remember that as far as Down syndrome is concerned, if the NIPT is normal or negative, and if the report is good with a good fetal fraction and Z-score between +3 and -3, the chance of having a baby with Down syndrome is extremely, extremely rare, and there is no evidence to go for testing for Down syndrome after a negative NIPT report, even if you pick up a soft marker. Now, the question and argument that people are going to say is that won't there be other genetic syndromes? Can't there be other genetic syndromes with an absent NB or an aberrant right subclavian artery? Yes, it is possible, but the prevalence of those disorders are extremely rare. And by picking up these abnormalities, whether we should go in for testing and doing a microarray or an exome sequencing solely depends upon the patient's wishes after proper counseling. And because here our aim is not to seek and destroy or to just be absolutely sure, the idea is to find out a relative risk and decide whether it is required or not based on the patient's wishes. You don't need to do an amniocentesis to rule out Down syndrome after an NIPT test says that it is low risk. The last scenario is when you have a previous affected child that hasn't been worked up and they land up at 12 weeks. There again, doing an NIPT is of no use because NIPT is not a magic test. It is only useful for a few chromosomal abnormalities. And if a previous child comes up which has not been worked up, follow protocol. Follow the same protocol that I talked about. And in the meantime, if it is possible, work up the index child. So the aim of this talk, and I hope I have achieved this, is to make all of you aware about the NIPT more than your NIPT provider or the lab person that comes to talk to you. Second is to report it properly, to interpret the report correctly, and get rid of this fear of or obsession of picking up the rare syndromes or rare abnormalities, and counsel the patient properly. Because the aim of fetal medicine has always been not to seek and destroy, but to inform, protect, and facilitate. Because we are essentially caregivers, and giving care, that's our superpower. Thank you. Thank you for listening.
Thank you so much, everyone, for being there. I can still see there are almost 450 people present in this webinar. Thank you so much. And I'm glad that I actually pre-recorded it because the weather in Kerala is totally unpredictable. And right now there are thunder showers happening outside, and I lost net connection probably 3 or 4 times. And so I'm really, really happy that I actually recorded it and there was no interruption for you while you were listening to that talk. And I hope this has given you a clear idea on what NIPT is and it will help you in your clinical practice. Now, I remember what I told at the beginning. I hope you listen to everything, because when you go into the quiz now, that's where that's going to create a difference. Over to you, ma'am.
Yeah, so we will go into the quiz now. I'll share my screen. Why did I share? Can you see the quiz, Vijay?
Yes, I can. Yes, I can.
I thought I hadn't shared it. I hope I shared with sound. 1 second. I'll just make sure I did the right sharing. No. Yeah.
It's gone now, yeah.
Yeah, now it's come back, right?
Yes, yeah.
Yeah, so I'm going to reduce this to 1. Okay. So this is the quiz instructions. The questions will be read out. I think I can turn off my video also. Yeah, the questions will be read out as seen on the screen, and immediately thereafter the question will be launched. There'll be a Zoom option box that appears on your screen, and you can answer. There's only one correct answer. You can answer each question only once. So if you tick it off once, you cannot change it once the Zoom option box is launched. You will get 15 seconds to answer each question once the Zoom option box appears. So first, Bijoy will read the question with the options. Then the Zoom option box will appear. And after the Zoom option box appears, you will see there is a timer here, and that timer will, sorry. Yeah. So you'll hear the timer like this. Sorry. Just give me a second, Vijay.
Yeah, sure.
So that's how the timer will time 15 seconds. And after the question is over, you will see on your screen what is the right answer. We will not discuss each question as it when it's over. We will discuss it at the end of the quiz so that your concentration is not lost. There is no negative marking, so it's good to answer all of them. Both the correctness of the answer and the speed of answering will be considered to arrive at a final score. The top winner of the quiz will get a specially discounted course at fetal medicine course at 50% of the price. But if they're already part of the fetal medicine alumni, then they can choose any other course. The name of the first top 5 quiz winners will be available, and the name of the winner will be declared tomorrow and can be seen at this link, which is given over here. You can note down the quiz, the link, and Pallavi from the Academy will also put this link at the and the chat box. If you have any questions about the results or the quiz, you can always contact Gynac Academy at support@gynac.org. So we'll start. All the very best, and we'll start off with the first question. Bijoy?
Yes, I'm ready. Yeah. Okay, here's the first question. I think this is not from. You have to go.
Oh. Puneet? Oh, sorry. Then I have brought in the wrong question. Sorry.
I was thinking suddenly, where did this come in?
No. Then I'll share it on my other screen. Sorry.
No problem.
I'll share it from the other screen. Just a question. Sorry. What happened? I have to first stop sharing. I'll just stop sharing. I don't know what happened. Do you want to continue? No, I don't know. This happened. Okay. You can see it now, right? Sorry, I'm going to share with sound. Yeah.
Okay. Yeah, we can see it now.
Yeah. I've gone to full screen. Yeah. So now this is the first question.
Okay, the first question is, a woman with NT greater than 3.5 millimeters should be offered one of the following: amniocentesis or CVS, combined test, NIPT, or termination of pregnancy. You can launch the question. Okay.
Move on to the next question.
Question number two. Question number two is
Stop sharing now.
positive NIPT for Edwards syndrome means CVS to confirm, amniocentesis to confirm, either of the above, or direct termination of pregnancy. You can launch the question. Okay, we go into the next question. NIPT versus combined test. All are true except both have the same negative predictive value. NIPT has higher detection rate for Down syndrome. Combined test picks up other significant aneuploidies. Both have the same positive predictive value. You can launch the question. Okay, we go to question number 4. Fetal fraction is calculated by length of the fragments of DNA, SNP based techniques. Fetal DNA cannot be separated. All statements are correct. You can launch the question. Okay, we go into the 5th question. Which of the following statements is true about fetal fraction in NIPT? It's more in obese mothers, is higher at gestational age less than 30 weeks, is higher in pregnancies with low PAPA, disappears from maternal bloodstream after 6 weeks. You can launch the question. Okay. Question number 6. The best screening test in twins is SNP based NIPT, combined test, genetic sonogram, none of the above. You can launch the question. Okay. Question number 7. NIPT low risk and the anomaly scan shows URSA. Options are recalculate the risk using genetic sonogram, amniocentesis to rule out Down syndrome, counsel and reassure on low risk of other aneuploidies, amniocentesis with CGH array. You can launch the question now. Question number 8. NIPT low risk and the anomaly scan shows tetralogy of fallow. Recalculate the risk using genetic sonogram, amniocentesis to rule out Down syndrome, counsel and reassure on the low risk of other aneuploidies, amniocentesis with CGH array. You can launch the question. Question number 9. Genetic sonogram at 22 weeks shows risk for 1 in 50. Would you do an NIPT, amniocentesis with FISH for 21, 13, 18, and sex chromosomes, amniocentesis with CGH array, or terminate the pregnancy? You can launch the question now. We come to the last question. Previous baby with cerebral palsy. Couple is now at 12 weeks. Do you offer CVS and whole exome sequencing, NIPT with micro deletions, combined test and workup of the index child, counsel, reassure, and do ultrasound surveillance? You can launch the question. I hope all of you got all those answers right.
Bijoy, should we go back from the first question? Would you go through the right answers?
I think we should, we should take the questions in the chat box, because these I've already talked about in the talk. No, so would it be repetitive?
No, you just say quickly the.
Or I'll share my screen so that I can explain it better that way. Yeah.
Oh, okay.
Yeah.
That's better.
You don't have to change the slide. Yes. Just hold on.
And we'll do the Q&As after that.
Okay. Okay, I have the quiz PPT, and we'll take. I hope you can hear the thunderstorms outside.
No,
No?
but we believe you, Bijoy.
It's raining cats and dogs here. Okay, I hope my screen is visible.
Yes, it is.
Okay, so as this is the first question, I hope, right? Or is it?
No, it's the second, I think.
Okay, let me go back. Yeah, this is the first question.
Oh, first one, yeah.
So as I told right at the end, when you have a high NT, when the NT is greater than 3.5, then you cannot do screening, because you need to do some form of invasive testing. It could be an amniocentesis or a CVS, and the choice essentially depends upon the expertise that is available in your area. And the reason being is that there is a almost 8 to 10% chance of other aneuploidies that you can pick up, which will not be seen on your NIPT. So that's why we prefer to do direct testing when the NT is greater than 3.5. Okay, I lost my power, but you can hear my voice, I hope.
Yes.
Good. So now all of you would believe me when I say that it's raining cats and dogs here. Okay, so we go to the next one. Here the NIPT is positive for the Edwards syndrome. Okay, 1 second. I'll just. Okay, I hope you can see me. So
Yes.
CVS, what do we do? Do we do a CVS to confirm? Do we do amniocentesis to confirm? You can do either of the above or go in for direct termination of pregnancy. Now, the important thing here is when you have an NIPT positive report for Edwards syndrome, you would have to do a amniocentesis, especially if you find that there is nothing on the ultrasound. If the ultrasound is negative and there are no findings, the best method would be to do an amniocentesis as the test of choice. NIPT versus a combined test, all are true except. Now remember that the NIPT, we are asking about what is false here. All are true except. So we're looking at a false statement here. And if you look at the negative predictive value, it is the same. It is 99.99%. So that's correct. NIPT has higher detection rate for Down syndrome. Yes, higher than combined test. That's also correct. Combined test picks up other significant aneuploidies. Yes, that's also correct because we're looking at a risk greater than 1 in 100. It would pick up all those significant aneuploidies. But both tests don't have the same positive predictive value. The positive predictive value of NIPT is much higher than the combined test. Fetal fraction is calculated by length of fragments of DNA, yes, because smaller fragments come from the maternal placenta, and that allows us to differentiate on the quantity of small fragmented DNA that is present. SNPs, they are DNA fingerprints that will allow us to know the quantity of different SNP that are available and circulating in the fetal fraction. Fetal DNA cannot be separated. We can only look at the quantity of small fragmented DNAs or quantity of the SNPs that are there for a specific DNA fragment. So all these statements are correct. Which of the following statements are true about a fetal fraction in NIPT? So we are looking at a true statement, not false statements. So it's definitely less in obese women. So more is wrong. It is higher at gestational age, less than 10 weeks is also wrong because you know that it increases after 10 weeks and it's best to do it after 10 weeks. It's higher in pregnancies with low PAPE, again wrong, because a low PAPE means the placental function is bad and therefore you're going to get less amount of cell-free fetal DNA. This was a question also that was asked in the chat box. Low PAPE means bad placental function, and bad placental function in turn means lesser cell-free fetal DNA. And yes, it disappears from the maternal bloodstream after 6 weeks, as I showed you in that graph on vanishing twins. So the best screening test in twins would be, what is the best screening test? Not the combined test, which I told you has a very low detection rate with a high false positive rate, not the genetic sonogram, but the best one would be the SNP based NIPT because it differentiates the fetal fraction of either of these twins. But having said that, also if you have other forms of testing, they have massive parallel sequencing or the routinely used NIPTs, even then they have a good outcome on regular testing. So you can use SNP based testing would be the best option here. Okay. NIPT low risk, and the anomaly scan shows, I think I can't see this here. It's okay. Shows URSA. So in those conditions, what would you do? If you have URSA and you have an NIPT that shows low risk, I already told you that you will not be worried about Down syndrome. You're not going to recalculate the risk using the genetic sonogram. You're not going to do amniocentesis to rule out Down syndrome. You're going to counsel and reassure them that there is a very low risk for other aneuploidies. And you're not going to directly advise amniocentesis and CGHRA. You have to counsel them, reassure them, and even then, if they want to go in for testing, that is where you have to respect the patient's choice. NIPT low risk and the anomaly scan shows tetralogy of Fallot. Structural malformations, there has to be no doubt we would go in for invasive testing, and here always the investigation of choice for us is going to be a CGH array, unless you find findings that are associated with certain aneuploidies, like you have a holoprosencephaly, if you have certain findings like rocker bottom foot, and where you're reasonably sure you're looking at trisomy 18 or 13, then you may think of doing a routine karyotype, but otherwise your investigation of choice is always going to be a CGH microarray. You did a genetic sonogram at 22 weeks and it shows a risk for 1 in 50. Would you do an NIPT here? Now here, the problem is the gestational age is 22 weeks. You do an NIPT, if you get a positive result, you don't have time to go in and confirm that result using an amniocentesis. And that's why the best test would be an amniocentesis. And for a genetic sonogram risk with a structurally normal fetus, you don't have to do a test that involves a microarray. You can just go in and look at fish for 21, 13, 18, and 6 chromosomes. And definitely you're not going to terminate the pregnancy. So the answer here would be to do an amniocentesis and not do NIPT very late, because then you would have to again do a confirmatory test later on. So previous baby with CP couple now at 12 weeks, what would you do? Will you offer CVS and whole exome sequencing? You will not. That is too much, because the baby is completely normal right now. The fetus is completely normal right now. You are not going to do NIPT with microdeletions because you don't know what has caused the CP in the first pregnancy. So the best method here would be to do a combined test and do a workup of the index child. And hopefully, if you get a result before this pregnancy advances too much, you will be able to do further invasive testing. I guess that's all. And I hope all of you got it right. And I'm sorry for the power disruption here.
Okay, Bijoy, what about the Q&As? Would you read it yourself? You can just turn on the...
1 second, I'll just check the Q&As. There are 52 questions.
I know. Some of them are, they themselves have said you've covered it earlier, sir. So...
Okay, so, okay. I'm only going to do the questions that probably I haven't covered.
Yes.
I hope that's okay.
Yes.
So the first one is, can we do NIPT if the mother is herself, for example, having trisomy 21? No, we can't, because we have to make an assumption that the mother is normal. So if the mother is abnormal, definitely we can't do the NIPT in that group. And usually trisomy 21 mothers would have problems with their fertility, and so would be using a donor egg or something like that. And you would have to do probably an invasive test, or a routine combined test, but not NIPT, because it is going to be not correct, because the mother is abnormal here. Why Z-score is used in not moms? Because when you look at statistical analysis, Z-score is much more accurate than multiples of median. And being a more statistically accurate test, Z-score is the formula that is used. Can NIPT work if the mother is mosaic for 21? Again, the same answer, no, it will not work. But sometimes we may not be aware of this, and not for mosaic for trisomy 21, it could be mosaic for 6 chromosomes. And definitely if the mother is a mosaic, you cannot use NIPT. So why do aneuploidies cause low fetal fraction? It's because, again, poor placental function. The trisomy 18 profile with low PAPA is the one that's usually going to have poor cell-free fetal DNA, and that's why aneuploidies can have low fetal fraction. What is the incidence of trisomy rescue in human pregnancy? Okay, I don't think we can actually predict that. It's very difficult to look at the actual incidence, and it's not very common, but it has to be kept in mind. That's why the false positive rates are not extremely high for NIPT. That's because the incidence is quite low, but that has to be kept in mind, and that's why it's not confirmatory. NIPT can detect only trisomy 21 right now. So how come in maternal malignancy abnormalities in chromosome 1 and 2 and all can be detected? No, you're right. But I'm talking about if you use an NIPT for the entire karyotype. Those tests are also being offered by most lab providers. And that time you can get these multiple reports. And you can also get multiple reports for trisomy 21 and 13. For example, NIPT turns out to be positive for 21 and 13. Then you know that it's most likely wrong, because the child cannot have both, and there could be maternal malignancy. Maternal copy number variants, I think I've already explained that in the talk. Basically, copy number variants are when you have deletions or duplications that are less than 5 MB pairs, and it creates an overrepresentation or an underrepresentation on your NIPT. And that's why it turns out to be positive or negative. How much high is high fetal fraction? How much high is, or you mean how adequate it is? So anything in the range of about 10, because 10 is an average amount of fetal fraction that you would get in a singleton. So anything above 10 would be okay. How is the Z-score calculated? The Z-score is calculated basically by looking at the mean deviation, the same thing. They looked at normals and abnormals, and with that normal distribution curve, They looked at how far away from the mean a particular value can be for it to be called abnormal. What is the cutoff value for intermediate risk of combined tests? I have already talked about that. How much does the test cost? Again, I don't think I can tell you that because different labs have different costs. Can NIPT be offered 6 weeks after fetal reduction? If you're doing fetal reduction, you can do it. You can offer NIPT, but you have to wait for at least 8 weeks, because 8 weeks is the minimum time that for the fetal fraction to completely disappear. But even then, there is a 2.6% false positive rate. So that has to go into your counseling while you talk to your patient. When maternal and fetal DNA cannot be separated, then how to know fragment size? I already told that. I've covered that in the talk. Can we offer NIPT as a primary test along with NT scan in the advanced maternal age group? Yes, you can, provided you do a proper NT scan and you have screened anatomically the fetus. But then again, understand that NIPT will miss out on all those significant, clinically significant aneuploidies. But again, the choice is to you and for the patient to decide. NIPT definitely can be offered in the higher age group directly after doing a proper NT scan. You said that when the fetal fraction is high and the Z score is low, it means it is false positive. No, I didn't mean that it is false positive. I meant that if you have a high fetal fraction and a low Z score means above 3 but less than 6, there is a strong possibility that it could be false positive. Please understand that there is not yes or no question. There's a high chance of that being false positive. For sex chromosome abnormalities, however, that does not apply because the mother could be a mosaic. Can you explain next generation sequencing? I have done that in the talk, but I'll just tell you what it is. It's like you have small fragments of DNA. So you take all those small fragments, you magnify or amplify them using PCR. And after that, you sequence them. You sequence them and find out from where these fragments have come. And then you align it with the reference chromosome. That's basically what NGS is. It's like taking small bits of DNA and asking them that question, where are they coming from? That's basically the thing about NGS. If dual marker shows high risk for trisomy 21, is it advisable to advise NIPT, which is again a screening test? If it comes high risk for 21, again, you have to employ your cutoffs. It depends upon where your cutoff is. If you are interested in reducing your invasive test rates, you have to use the cutoffs that I talked about. But if you're only thinking about not missing out on picking up an anomaly or an aneuploidy, then probably you have to decide what you want to do in your clinical practice. Yeah. Can dual and quadruple marker tests be done in multiple pregnancies? Combined tests can be done, but we do not offer quadruple test in multiple pregnancies. Till what gestational age can we offer NIPS? Again, I said not in mid-trimester, because then if it turns out to be positive, that is like at 20 weeks or 21 weeks, if it turns out to be positive, then you will have to do an amniocentesis. And by that time, the result comes out, it would be too late. Can you brief NIPT in twins? That's a big question. I've already mentioned it in my talk, so it'll be difficult. False positive rate of NIPT, we have already talked about that. Isolated URSA, what to offer, we have talked about that. 96 kgs diabetic at 10 weeks, double marker is 301, NT 1.5, nasal bone present. Do you advise NIPT? Now, 96 kilograms is not a good maternal weight for us to offer NIPT. But now, because there are labs that are doing these tests for very low fetal fractions, and that's what I said, limit of detection. You have to find a lab that can give you a result for very low fetal fractions of less than 2%. And in those cases, maybe you can offer it. But otherwise, it is very difficult in an obese woman, and you just have to tell her that her risk is in the intermediate range group and probably get on with it. Role of NIPT in Rh negatives. Yes, now you can look at the blood group of the fetus by using NIPT. It's available. The test is now available in India. So it does make a difference when you are trying to do surveillance in Rh negative pregnancies. In case of normal NIPT and soft markers presence at 20 weeks. Can normal NIPT soft markers at 20 weeks, can we proceed with no invasive testing with proper counseling and consent? If the NIPT is normal and a soft marker is present, you're not going to be worried about Downs. The other abnormality is pretty rare, and yes, counseling is the option. NIPT and triplets, no. Don't have no studies are there yet on NIPT and triplets as yet. So triplets, we are basically on our own. We don't have a good screening test as yet. Okay, I'm glad that there are a few that I can skip. Where to type the answer, I'm definitely going to skip. Okay, there are a few alphabets as questions. No combined test with unossified NB in the second trimester can we offer NIPT? The same problem arises. NIPT in the second trimester is going to create a delay in your final result. When you pick up a soft marker in the second trimester, best option would be NIPT if the patient wants it, or to do a genetic sonogram, and if the risk is high, go in for invasive testing. And if the genetic sonogram risk is in the intermediate risk group, you can offer NIPT. NIPT is a screening test. Age risk is concerned into, yes, age risk is considered into the calculation of NIPT to decide the positive predictive value. Which lab provides SNP based testing? I'm afraid I cannot take lab names here, but there are labs. You will have to find that out. If we are doing fetal reduction for triplets after NT scan, I've already answered that. Microarray when to do, whole exome sequencing when to do. I think that's a totally different talk on which test to offer and when. Recently had a case of NIPT being low risk for trisomy 21, and fetal fraction was normal and Z score was okay. Absent NB at 20 weeks, did amnio and turned out 21. How to go in this scenario? Now that's again what I'm telling you. Anecdotal practice is not what makes fetal medicine. We have to understand that there are going to be exceptions to the rule. But if you look at an exception to the rule and decide to base your entire practice on that, you will be doing a lot of unnecessary tests just to pick up that one abnormal. As long as we stay within the guidelines and the protocol, we should be reasonably safe. SNP based test NIPT can be done in triplets. No, we are not there yet. Role of NIPT that we have done. NIPT, no, okay. Okay, we've done all this. Which test can be offered to diagnose 22q deletion? Now it depends on why you want to do the test. If you're finding a cardiac anomaly and you are suspecting 22q deletion because of a conotruncal abnormality, absent timers and things like that, you can do an amniocentesis with a microarray. Or if you have a previous child that is affected with 22q deletion and you found that one of the parents are carriers, again, you can offer an amniocentesis and microarray, and that would be the best test. In a low risk population, where both parents are normal and ultrasound is normal, we are not going to offer testing for 22q deletion because we are not sure if you pick up 22q deletion, one, if it's going to be false positive, and second, if it's true positive, what are the chances that the baby is actually going to have a phenotypic abnormality? Okay, we've done that. We've done that as well. Okay. If FTS screen is positive for trisomy 13 and 18, best option would be CVS or amniocer. I would still say that if you have a screen positive test for 13 and 18, and if you have a completely normal ultrasound, it's best to wait. But if your ultrasound is showing markers, then CVS is definitely an option. But the combined test does not make the distinction between placental mosaicism and confined placental mosaicism and trisomic rescue. So whenever you have a screen positivity on the combined test, CVS would be a good option. What workup for the previous CP child? That's a whole different talk on genetics, where we look at the child and look for handles to help us to identify what the genetic syndrome is. What to do if risk is 1 in 50? You told high risk indicates other influence, so only fish or even microarray. So if you decide to bring your cutoff down to 1 in 100 on the combined test, I mean if you get a high risk of greater than 1 in 100, then you have a choice of either doing just an amniocentesis to rule out Downs, or you can also tell the patient that there is a possibility of other aneuploidies and offer them a microarray. And it depends on the patient on what test you're going to do. Definitely, you're going to do amnio for Downs. Along with that, if they want to do a microarray as well, they are well justified because you would pick up all those extra aneuploidies which you could not pick up on a routine karyotype. Role of cell-free DNA, RH, I've already told that there is an NIPT test that is available that will allow you to look at the blood group of the fetus. If vanishing twin is seen at 11 weeks in USG, when can we do the test? If you see it on 11 weeks, if you see a vanishing twin, as I told you, after 14 weeks, it starts to dip and it's the lowest after 14 weeks. But to be safe, we offer the test after 6 to 8 weeks. So 6 weeks would be reasonable, where you would reach at around 17 weeks, but counsel the patient about a 2.6% false positive rate. If you're doing an invasive test for increased NT, what genetic test would we do? Definitely microarray for increased NT. Soft markers, I'm not going to do. NIPT validation in donor embryo. Yes, you can do NIPT for donor embryos as well, because it's the same thing. We are only looking at overrepresentation. So if the mother is normal and you have fetal fraction coming from the donor embryo, if it is showing overrepresentation, it should work as well. Who can order NIPT medico legally? That's a gray area because there is no legality on who can offer the test. I think the problem is on how you interpret the test, and that's why anybody can go and get an NIPT done, and the decision depends on how you interpret it. How to proceed when we see an intermediate status? Okay, that's done. NIPT amniocentesis. Okay, okay. There is a basic question on statistics, standard deviation norms, but I think that's difficult for us to address here. Please opine about NIPT for DiGeorge, especially if isolated URSA. Would you follow a false positive NIPT for FGR? Okay. I wouldn't do NIPT if I am suspecting DiGeorge. I would probably go in for a confirmatory test. And if you have a false positive result on NIPT because of very low fetal fraction, yes, it indirectly points towards the possibility of FGR. So low fetal fraction could also be a marker for FGR developing later in those fetuses. Okay, first time is the same thing. Can we still detect a part of fetal fraction after 20 weeks or a scum? No, no, sir. Okay, the question here is, can we detect fetal fraction after 20 weeks? The fetal fraction continues to increase till the baby is delivered and disappears only after the baby has been delivered. Till 20 weeks, the increase is very incremental. It increases by only 0.1% per week till 20 weeks. And after 20 weeks, it increases by 1% per week. So there is an exponential increase in fetal fraction after 20 weeks. So NIPT is very good after 20 weeks, but the problem is we can't use it because by the time we get a confirmatory report, our termination window would have already closed. And that's why there is no point in doing an NIPT very late. Which is the best NIPT test to be offered? So many names in the market. Yeah, I cannot tell you that, because I can only tell you what all you should ask your provider. Ask your provider all these questions that we talked about, and you will be able to pick your test. NIPT positive for multiple chromosome involvement, then how to screen for any particular tumor? It's a difficult question. We will have to work up the child with the help of the mother, with the help of an oncologist, and run a number of tests. Because if you have multiple abnormalities, we do get worried about it, and sometimes we cannot make a diagnosis during pregnancy, and maybe we'll have to refer her to a specialist after that. What about NIPT or combined test in mesenchymal dysplasia? Okay, that is difficult to say. We don't have any data on that, but again, it would turn up as false positive on your NIPT. Mesenchymal dysplasias, yes, we talked about that. Can we rely on NIPT for determination? Yeah, but none of the lab. Okay, the question is, can we rely on NIPT for determination of sex of the fetus in indicated cases? None of the labs are going to report that because that's a strict no in our country. So the best option would be to go in and scan and find out, for example, if you're looking at an X-linked recessive disorder, wait for 12 weeks, look at the sex of the child and decide whether you want to go in for invasive testing or not. Is there an intermediate risk for quadruple test? We haven't used quadruple test in a contingent manner because we always describe it for the combined test. Microarray 750K or 315K for structural abnormalities on USG, that's an ongoing debate. Actually, people say do the 315K because you don't get abnormalities that you're not prepared to counsel about, because you would get a lot of variants of unknown significance. But I personally prefer to do a 750K and then counsel the patient accordingly. But that's still an open debate. What is genetic sonogram? It's not possible here. Can a combined test have high risk for trisomy 21, 18, 13? Yeah, we already discussed that. Multiple positivity on NIPT, most likely false positive. Even if late, parents might be prepared to do an NIPT at a later gestation. Yes, if the parent wants to do an NIPT even at 22 weeks because she's afraid to go in for an amniocentesis, they are well within their rights to ask for that test, and you can do it because if the patient wants it, NIPT is their right and they can do it. But the problem is you should counsel them. If it turns out to be positive, then again, we would have to do an amniocentesis to confirm. We will not take any irreversible decision like termination of pregnancy based on an NIPT result. Okay, we did that. Is there a cutoff BMI to offer in NIPT? Most of the papers have looked at weight categories. BMI has not been seen in most papers because of the problem of lack of data, because they look at the weight of most of the mothers. The height is not usually recorded, and that's why BMI cutoffs are not clearly available in most papers. The weight cutoff that they usually take is around 78 to 80 kilograms. But BMI would definitely be a better cutoff, but none of them have actually given a clear guideline on that. Early onset FGR on TIFA scan, no soft markers, normal uterine artery Doppler, mother 32 years old, FTS low risk. Early onset, I think that's not a part of this webinar. Would you recommend NIPT when there is an isolated NB at 19 weeks? Again, it depends on the patient's choice. I would do a genetic sonogram, look at the final risk, and if it is high, I would offer amniocentesis. If it's the intermediate risk group, I would just tell them to forget about it. But if it is in the intermediate risk group, I would ask them to not worry about it. But if the patient is still concerned about it, then we could offer an NIPT. Okay, which lab does NIPT? Okay, we can't talk about labs. Okay, thanks a lot. Okay, 47-year-old ICSI with own oocyte, normal NT, combined test is 1 in 700 NIPT. 47-year-old with own ICSI. I mean, that's a remarkable 47-year-old to have that. It's extremely rare. But again, if you have NIPT low risk, you can believe that test, and there is no need to worry about downs because there is an echogenic intracardiac focus. So the question was 47-year-old ICSI pregnancy, NIPT low risk, and anomalies can show echogenic intracardiac focus. We are not going to offer testing in that group. Okay, genetic sonogram 1 in 50, and there is ventriculomegaly on the scan. What can we do? Do we go for microarray? Yes, you could go for microarray. Yes. Combined test screen negative, including unossified nasal bone. Nasal bone is unossified. Should we go ahead? Okay, if the combined test is negative after doing after including the unossified nasal bone into the risk, no further testing is required for Down syndrome because you've already ruled that out. What are the legal implications if there is a scenario of trisomy 21 after low risk on NIPT, amnio done after the finding of unossified nasal bone in the second trimester? What is the legal implication of amnio? There is no legal implication because your NIPT says low risk, and you have to counsel the patient that there is a very, very low risk of having a baby with Down syndrome. And if it turns out to be trisomy 21, you have already counseled the patient on it. There is no legal implication on that because it has already gone into your disclaimer. NT6mm, which test to offer, microarray or exome sequencing? I would definitely offer microarray first and then follow up the patient, and at 16 weeks do a review scan. And if the nuchal fold is still high, I would do an exome sequencing. Should NIPT sample be collected only in hospitals with PCPNDT certification? Actually, I'm not sure of that, but yes, if you're doing any form of testing that involves, you need a PCPNDT certification. So I don't think you will be able to do it in a center that does not have it. Okay, NIPT is low risk. Okay, genetic sonogram. DCDA twin referred at 18 weeks gestational age with fetus B having intracardiac echogenic focus and pilectasis. How to proceed? Okay, it's the same thing. When you just as if you do in singletons, if you have two markers, you do a genetic sonogram and see what her final risk is. If there is a family history of trisomy 21 and the combined test is 1 in 250 for trisomy 21, she's 18 weeks now. Again, the same thing. You have to decide on what the patient wants. Okay, all of this is covered.
I have a feeling it's not going to end, but
I don't know. I mean, there are like,
how many more are there? I think the common one is monoamniotic twins.
There is a monoamniotic twin question.
Yeah, lower down.